I'm Jared O'D, Director of Training here at Dynamis, and I'm going to be talking to you today about one of our recent training courses.
What was the training course and how did you prepare for that?
So we were asked by a children's hospital to go and help them with the various different kinds of encounter that they have at their hospital. And we found out some interesting things about that, but essentially we were there to prepare their training team so that they could deliver an in-house training program to help all the different staff of the hospital in the different ways that they might have to interact with visitors or patients coming in, and at varying levels of cooperation, let's say, with what's happening at the hospital, keeping everybody safe.
What were the particular problems and challenges that the team were experiencing?
Yeah, it was interesting. When you first start doing a training needs analysis at a hospital, you expect that many of the issues you're going to have are between the clinical staff and the patients, let's say. Difficulties in asking people to take their meds, or finding confused people in the corridors who need to be helped to go to where they're going. But quickly at this hospital we found, and at many hospitals, what you find when you do the training needs analysis is there's so much going on. There's so many people who visit our hospitals that you end up considering all sorts of other people. So there's various levels of staff. So you have what we might call the gatekeeper staff. People who their job is to make sure people get to the right place, or that things get to the right place. So you've got your porters, you've got your reception staff, things like that. Security often fill that role as well. Then you have clinical staff and nursing, doctors and specialists. They all fulfill different roles, and so the types of conflict they get into are also really varied. So we did some surveys with the team and then found out some of the challenges that they're having. And then of course what we like to do is when we start the training, we always start with a fairly in-depth discussion really about what are the most common, most risky, most challenging situations that the teams are getting into. And then we use those as the curriculum almost for the training.
So it's quite specific to the experiences that the team themselves were telling you about.
Yeah, absolutely. Yeah, we have to do that.
And very varied from what you were saying.
Yeah, so often we talk about having 4 or 5 core scenarios that we might use with a team, but with this team, and because they're trainers as well, so they're going to have to cover everything that goes on at the hospital, all the different kinds of encounter. I think we ended up sort of isolating 9 different scenarios that they were working on, and that to be able to deliver a training session based around one of those scenarios, or all of them for some of the staff.
So it would be good to hear an example of one of those scenarios. So a common problem that was being experienced by the teams in the hospital.
Yeah, so going back to one of the earlier points, one of the things you find at a children's hospital in particular is that the staff are always having to deal with parents. So parents who are stressed out, afraid, scared, worried about their kids. And then maybe they also have very high expectations of what the hospital can do, what the staff can do. So in this instance, one of the key scenarios that we worked on very early in the course was a staff member coming across a parent who wanted to have an extra bed put into the child's room so that they could stay over, so that they could rest when they needed to, and be there when the child wakes up and things like that. And of course, you can't have every room at a hospital able to have another bed put into it. You wouldn't have enough beds, you wouldn't have enough space, and so on. So the facts are, the rules of the hospital are that can't happen. The tricky bit comes then when sometimes the staff have to make exceptions for that, quite justifiably as well in some cases. But that's a really good scenario for us to work on, because there are things the staff can do before they arrive into that situation to prepare themselves and achieve what we call emotional equilibrium. So they can be better prepared, in a better space, in control of themselves as they walk into that situation. So there's actually quite a bit of work to do on that end of things. And then as they come through that doorway and they encounter that parent, we have a set of tools called Non-Escalation. So How do you present yourself? How do you introduce yourself? How do you make first contact with somebody in such a way that the interaction's more likely to go in a good direction? And then there's listening carefully and empathizing with the person and trying to find a solution, even though there might be rules, procedures, policy that you have to navigate in doing that. So that by itself, that one scenario was really, really useful for us to start putting in a sort of a foundation of managing conflict effectively and professionally communicating.
Most inspiring or the best moment on the training from your perspective as the trainer?
Yeah, and as a person leading a train the trainer course, one of the key moments you have is realizing that these people who walked in on first day of the training course to become trainers, often they come in and they're quite, anxious really about the pressure about becoming a trainer, and especially about becoming a trainer in conflict, and then even more so in becoming a trainer in physical interventions. Not everybody has the background in doing physical skills training like that. So the key moment, I suppose, is when you turn around maybe halfway, 2/3 of the way through the course, and you start giving instructor candidates more opportunities to teach. Now, on our courses, an instructor candidate gets an opportunity to teach on day one, which I think is relatively unusual, but that's the way we do it. But maybe half or 2/3 of the way through, when you give them maybe a longer block of the course to teach, and then you see them stand up in front of a group and actually start, doing the work of being a trainer, instructing the skills, having the practices going on in front of them, and then providing feedback, and that's a really good moment. I think it's testament to being able to take people on that journey from being unsure if they can do it to then actually doing it for the first time really competently. That's really good.
Did they have any particular challenges or particular parts that they appreciated very much?
Well, let's start with the learning. I mean, what we covered with them, in order to make the training program they're going to deliver as robust and as broad as possible, was we covered off a full suite of conflict management methods. So to cover things like non-escalation, de-escalation. So non-escalation means how to have everyday interactions with people at the hospital, whether they be visitors or patients or other people, colleagues from different departments even, and how to have these everyday interactions with them in such a way that they don't become something that then deteriorates, if you like, or how we treat people in that initial contact and listen to them and empathize with them. Another topic in that conflict management methodology is de-escalation. So many of the more senior staff will only be called to talk to a patient after something's gone wrong, after a complaint's been declared or an issue's been disclosed or somebody's getting upset. So they literally have to turn a corner and immediately go to work on slowing things down and de-escalating a situation. And then, especially for the mental health staff, for some of the ED staff, some of the time, they need to be able to recognize when somebody's in crisis, when we've got an emotionally disturbed person standing in front of us. And they need a slightly more specific and a slightly more empathetic methodology to deal with them. So we call it crisis management, or dealing with people with cognitive difficulties. So that was the foundation. So how do you, with your words and your behavior, make sure that we're keeping everybody safe? Then on top of that, we build a whole platform of physical skills. We call them protective physical interventions. From low-level prompting and guiding, where somebody just needs help to understand where they need to go, and maybe a physical touch would be the best thing to do for them. We work on personal safety tactics, how to protect yourself if somebody's, for want of a better word, lashing out. And then moving towards sort of holding tactics for these lower risk situations with children. And then beyond that, looking at holding tactics and physical interventions and how to stabilize somebody if there's more risk, these higher risk encounters that we talk about. So a full spectrum of those protective physical interventions. And then, because this was an instructor course, the third pillar is a scenario-driven training approach. So very unique to the way we do things. and based on work we do with Professor Chris Cushion at Loughborough, we teach the trainers how to deliver the training in context. So that's why we talk about scenarios all the time. And there's a very specific, very high-level methodology there for trainers to really create engaging, efficient, and effective training sessions. Throughout those three things, I think, just reviewing the comments from the learners today, the guys found that in all three of those domains, there was something that really helped them in their work. So how to talk to people, how to keep yourself and others safe. And then for this team who were going to have to teach that, the scenario-driven methodology was really helpful. So I've started talking about the three pillars of our approach, and I think they support each other really well. And I think, like we say, it creates effective training. So I think they appreciate many aspects of that. There's probably one that stands out, and a little pet topic of mine, which is breakaway skills and self-protection, personal safety training. We've really boiled that down into something that's very simple, can be learned relatively quickly. I mean, it can be learned well in any block of time that you give me. So if you give me learners for an hour, I can teach them something very simple that can help them to stay safe to an extent. Now, if you give them to me for 3 hours or a full day or 2 days just to focus on personal safety, then we can build on that. But it's building on their ability to do those simple things as opposed to building it out wider in terms of more skills. So a lot of the breakaway skills that we see, they're kind of on a one-to-one relationship with what the assault is, being grabbed by the lapel, and then there's a technique for that. So it's a one-to-one ratio.
So a lot of content, in other words, because there's numerous different ways you could be in trouble.
That's right. And so, historically, there's been about 15 techniques. Somebody decided that, somewhere in the teens was the right number of different ways that you could be assaulted. Being hit, being grabbed, being, grabbed by the arm, grabbed by the hair is one, of course, that we see. Somewhere along the way, it evolved into having 15 different techniques for 15 different assaults, or more, or slightly less sometimes. But we've been able to break that down and really look at the way those assaults develop, and then the way the human body works, and sort of put that together in such a way that the breakaway system we teach is really, really quick to learn initially, and then it can be refined over time. But most of the learners, and definitely the trainers, really appreciate that, because it cuts down the amount of things they have to try and remember. And as we know, in a real serious physical confrontation, you can't stop to try and remember. You just have to act and get free and break away and get to safety. So I'm really proud of the work we do on that particular skill set, because it always produces really good results, and people walk out of the room feeling much more confident.
Were there any particular challenging moments for this particular training, or any surprises?
Yeah, I suppose the constant challenge is that you have language barriers, and then you've got cultural differences, and then you might even have other things that pop up that are somewhere between the two. So language is one thing, but then how people communicate is another. So what's persuasive in one culture can appear aggressive in another. What's a redirection in one culture can look like fobbing somebody off in another, or be very triggering for somebody. One of the key strategies we teach in a redirection is that, if somebody's being abusive or resistant with you, or they're throwing a few insults your way, you're slow, you're too slow, you're not good at your job, whatever it might be, that you would say to them that you understand that they're feeling frustrated at the situation they're in, but that you're doing your best to help, and that you might suggest some solutions. But that actually recognizing that somebody is frustrated and then saying it out loud, in some cultures that can actually be seen as quite a trigger. So there were some issues around language and culture, which we've been navigating for many years now, really. But when you're looking at trainers who are considering these things for the first time, it can be pretty tricky to navigate.
So, are there any recommendations that you would make to other healthcare organisations based on your observations and experiences with this particular group?
Yeah, I think the answer to that is, should hospitals be working on communication skills with their staff? And I think the answer is yes. We on this course we actually brought in a group of novice learners. So one afternoon, about 2/3 of the way through the course, we actually got a bunch of the ED nurses to come up and stand in the room. And then we let our new instructors loose on them. But what was really interesting is that many of them had never had any input on communication skills or personal safety skills, probably since they'd done their initial training, if they'd done any of that during their initial training. So, small things like being aware of their distance and positioning, their body language, how they do that, how they make that first interaction with a patient when they come into the hospital. There's an awful lot there that sets the tone for how things will progress from there. And we get a lot of those ideas from our partners at Vistelar. This idea of setting the social contract and reinforcing the social contract in the hospital at every touch point. Our colleague Joel Lashley tells this story about the library principle. Very simply, people who arrive into a library, we can assume that they know how to behave. Everybody knows the rules in the library. But people turning up in the emergency department of a hospital, they have many expectations, they're very stressed, and they don't necessarily have an awareness of or a learning about how to behave in an emergency department. So our staff have to help them. So if they raise their voice, our staff need to help them to understand that that's perhaps not the best way to get what they need at this time. And so the idea that hospitals would just hope or assume that their nurses, clinical staff, even their gatekeepers can effectively communicate with all of the visitors and the people coming into the hospital, some of them for the first time, I think that's a real issue. That if we're trying to improve our patient satisfaction scores, if we're just trying to reduce conflict, if we're trying to bring our number of restraint incidents down, that can be the first place to start, rather than looking at personal safety as a first topic, or even physical interventions. So really, is how do you set up the social contract? How do you educate the people coming into your hospital as to how we're going to treat each other, how we're going to do business? As my colleague and mentor Gary Klugowitz says, we have to set this supportive atmosphere from the very beginning. And I think a little bit of training can really help with that.